All right. Video number three is maintenance therapy. Pretty much going over the drug therapy COPD patients need for maintenance. We're going to get into a lot of uh, drug therapy, what drugs we're giving them, initial treatment guides, go through different groups, reassessing the patient and adjusting as needed, the progressive needs of COPD patients. We'll go over inhaled therapy, um, inhaled corticosteroid considerations and factors for that treatment. So a lot of drug talk in this video. All right, so drug therapy for COPD. We have bronchodilators, which, as we all know, is need for that immediate relief of symptoms. Get the long acting that provide that sustained relief and improve lung function. You got combo therapy with that for individuals with that persistent symptoms. Inhale corticosteroids used in combo with LABAs for individuals more severe COPD and history of exacerbations. This next one was in the brochure. I could not pronounce it to save my life, so I'm just going to call it PDE4 inhibitors, which, according to the brochure, it's for severe COPD with chronic bronchitis symptoms and frequent exacerbations despite other treatments. So, sounds like if things ain't working well, we're gonna give this a try. Then also oxygen therapy for that severe hypoxemia. And then, like we've been touched on before, vaccines. So a lot of these different names is very common with COPD patients. Shoot, most of them can tell you what this and that does because they've been taking them so long. All right, so just to give some examples of what some of the most common things we'll see dealing with COPD, bronchodilators, everybody knows albuterol, levoalbuterol, LABAs, things like salmeterol, formoterol, anticholinergics, your short acting like ipratropium bromide, long acting tiotropium, ICS, inhaled corticosteroids, budesonide, fluticasone, furoate, things like that. Then your combos. Most common one when you ask somebody what they're taking at home, a COPD patient, most of them are taking that trilogy if it's real bad. Symptom wise, that trilogy ellipta, which is a LABA LAMA, and ICS combo, which has proved to be very, very effective. So it's pretty much all the drugs you're going to see. Now, how we get to which ones are prescribed, which ones do we start with, that's what we're going to really, really dive into. So initially, this is our treatment guide. All right, so it's going to be based on the patient's goal group. It's currently focused on symptoms and exacerbations. Like I said, going back to dyspnea and exacerbations, pretty much what we're looking at and how to assess and initiate treatment. Choice of medications to use within each group depend on cost and availability, plus the clinical response balanced against side effects. So looking at what's working, what's not working, and changes that need to be made. These groups are based on assessments of symptoms and exacerbation history. And then the goal is to tailor treatment plans to individual needs, optimizing symptom control and prevention of exacerbations. All right, so we're going to start with Group A, low symptom burden, low risk of exacerbation. Pretty much just giving them some bronchodilators. It could be short, SABA or LABA, short acting or long acting, based on its effects on the breathlessness. LABA is preferred choice, except in patients with very occasional breathlessness. Should be continued if these should be bronchodilator treatments should be continued if there's benefits documented. So that's Group A, pretty much the lesser group. Next, we're going to go to Group B, which is the LABA and LAMA group. So for this group, that combo is the initial recommendation. choice if they're not already just taking a llama. Um, Group B patients are likely to have comorbidities that may add to their symptoms and impact their prognosis. So a lot of these patients got just a lot of bad stuff going on. These possibilities should be investigated and treated. So again, this group, higher symptom burden, but low risk of exacerbation. Then the last group is going to be group E, probably the highest maintenance group. So it's a LABA LAMA group as well, but you see in parentheses um, an added ICA inhaled corticosteroid if needed. So this group has a high risk of exacerbations, two or more moderate exacerbations, or one or more leading to hospitalizations in a year. LABA plus LAMA is the preferred choice. In the brochure, it said studies said that the use of LABA LAMA ICS is not encouraged, but if it's indicated, then it's preferred over a LAMA plus ICS if there's a history of exacerbations, according to the brochure. All right, so that's pretty much the groups. That's where they start. This is where the initial treatments are guided. And then after the initial treatment, we're going to have to reassess, look at the patient's symptoms and stuff again, and go through the same process, which is pretty much the slide right here. So following initial treatment, the patient's going to be reassessed, review the patient's response to the treatment, the treatment initiation, adjustments may be needed. So let's review the symptoms, exacerbation risk, previous history, blood eosinophils, then assess, look at their inhaler techniques and adherence to their medication, and then adjust. May have to escalate or de-escalate, switch inhaler, and use different LABAs. So many, it's not a one size fits all chart. So many different ways. Each patient, each case is different. All right, so looking at those progressive needs. So looking at that dyspnea, that persistent breathlessness or exercise limitations, we're going to have to add something. Two LABAs, two long-acting bronchodilators recommended, or, switch inhaler devices. See what works. It's a lot of trial and error, it seems like, after reading that brochure. Exacerbations, another big key. You may have to escalate to that LABA plus LAMA combination. Further escalation to that LABA LAMA ICS. Like I said, that trilogy is very popular. And then patients that are already going through that LABA ICS treatment, if it's under control, continue. If not, may have to escalate to the LABA LAMA ICS combination, or if it's major symptoms, gonna have to switch to LAMA and LABA. So that long-acting bronchodilator with the long-acting mucineric. Excuse me. All right, so that's how we look at progressive needs of a patient with COPD. All right, so now comes the managing the inhaled therapy. It's 33 different inhaled therapies containing different bronchodilators. Definitely not going to go through each one, but that's a lot of different therapies that can be done. 22 different inhaled devices. So out in the world, you see so many DPIs, MDIs, NEBs. There's just so much. I just named a few of the most popular ones, at least the ones I'm familiar with. Servant, Performist, Spiriva, Incrus ellipta. Um, so Servant, and that's that's the LABAs, then Spiriva, the LAMAs, Pulmicort, your ICS, and then the last two boxes are pretty much different combos. Symbicort, Brio ellipta, Trilogy ellipta. All these are just different combinations that you'll see. All right, so the IC inhaled corticosteroid considerations, regular treatment with ICS increased risk of pneumonia, especially with severe disease. Triple inhaled therapy of LABA LAMA ICS, such as Trilogy, really improves lung function, symptoms, and health status and reduces exacerbation. So as you can see, studies show that's why it's so popular. And then another big key is COPD that patients with asthma features, treatment should always contain an ICS. So if you have a patient with COPD, but they have some of those features of asthma symptoms, then they should always get a corticosteroid. And then factors for ICS treatment. So strongly favor use with a history of hospitalizations for exacerbations, two or more moderate COPD exacerbations per year, history of asthma. You're definitely you want to use ICS. A little bit lesser, but favors use is a moderate moderate exacerbation per year. Might want to consider ICS as well. And contraindications, though, if the patient has repeated pneumonia events or a history of mycobacterial infection. So these are the factors for ICS, and this is going to wrap up video number 3. Thank you for listening.